Our next topic is blood transfusions, and the cardiovascular system does minimize the effect of blood loss by a couple of ways: reducing the volume of affected blood vessels and stepping up the production of red blood cells, because the body can only compensate for so much blood loss. So, a loss of anywhere from 15 to 30% can definitely cause weakness and pallor, and then if you lose more than 30%, that's potentially fatal. It's a very severe case there, and you may go into shock. Death from shock can result because of low blood volume, because you have to replace the volume immediately. It's much more important that you replace blood volume with something, say, a normal saline or a multiple electrolyte solution called Ringer solution, because that mimics plasma electrolyte composition. Then you actually replace actual blood loss. That would need to happen later. So after replacement of volume restores adequate circulation, we would need to replace or compensate for that lost oxygen carrying capacity of the blood because of the lost red blood cells. So common types of transfusions include whole blood transfusions, where we're going to transfuse both plasma and the formed elements, and these are usually used only when blood loss is rapid and substantial. Much more common are infusions of packed red blood cells, or PRBCs. So this is when plasma and white blood cells are removed. This is definitely preferred if we're trying to restore oxygen carrying capacity. Blood banks usually are going to separate donated blood into components, so into their formed elements, into plasma, or even different types of the formed components, and the shelf life of blood is about 35 days. Human blood groups of donated blood must be determined because transfusion reactions can be fatal. So this is how we're going to move on to blood typing and talk about how we determine blood groups. The human blood groups are numerous, but we're only going to look at a couple. So let's establish some kind of ground rules. So red blood cell membrane, so the cell membranes of red blood cells, they're going to bear many different antigens. And you can think of these antigens kind of like tiny molecular flags that sit in the plasma membrane of these red blood cells. And some of these are going to determine blood group, but a lot of them are also just surface receptors, or they're going to kind of let the cell know what's going on around it. So that's what we're calling antigens. An antigen is anything perceived as foreign that can generate an immune response. Now, these antigens on a red blood cell, as long as they're in your body, they're self-antigens, and your body won't mount an immune response against them. But say you were to give your blood to someone, and they didn't have the same type of blood as you. Well, then the antigens, the tiny molecular flags on your red blood cells, would be viewed as foreign to this other individual that doesn't have the same blood type as you. Red blood cell antigens are oftentimes referred to as agglutinogens. That's because they promote agglutination, that's clumping. So agglutination occurs when there is a mismatched blood transfusion. And a mismatched blood transfusion is going to occur when blood, donor blood, is given to a recipient, and that blood is viewed as foreign, so the blood types don't match. That causes this clumping reaction, and when the blood clumps, it tends to lyse the red blood cells, and we get hemoglobin released into the bloodstream, and the bloodstream actually doesn't deal with hemoglobin very well, because hemoglobin is a big molecule, it's a protein, and it doesn't filter through the kidneys. So it can cause renal failure, so that's potentially a fatal reaction. What we would do with a mismatched blood transfusion is treat the symptoms and definitely try to dilute the blood so that the kidneys can handle the excess hemoglobin. So there are at least 30 naturally occurring red blood cell antigens, and the presence or absence of each antigen is what we're going to use to classify or kind of establish these blood groups. Some examples of blood groups include MNS, Duffy, Kell, Lewis, but these are all really weak agglutinogens. We rarely have a reaction if these blood groups are mismatched. And so they're not usually typed unless the patient is getting a lot of blood from a donor. So if someone needs several transfusions, we're not really going to type for those blood groups. What is typed, what is important because they are stronger agglutinogens, are the ABO antigens and the RH antigens. So the ABO and RH blood groups cause the most vigorous transfusion reactions, therefore they're the major groups typed. Let's look first at the ABO blood groups. Now the ABO blood groups are based on the presence or absence of two agglutinogens, A and B, on the surface of red blood cells. What this means is if on the surface of your red blood cells, you have an A surface marker or an A antigen, then you have type A blood. What if you have an A and a B surface marker or antigens? Then you have type AB blood. If you don't have an A and you don't have a B antigen on the surface of your red blood cells, then you're type O. You can kind of think of type O as type 0 because they don't have the type A or B antigen. And then if you just have the type B antigen on the surface of your red blood cell, then you're type B. So the blood types for the ABO blood groups in humans are type A, type B, type AB, and O. And you may be wondering, where does the positive and negative come in? We're going to get to that. But that's what is meant by presence or absence. So what is there versus what is not there determines your ABO blood group. Now, blood may contain preformed anti-A or anti-B antibodies, depending on your blood type. And essentially what this means is your body has antibodies to fight off the blood types you don't have. So if you have type A blood, in your plasma, there's the type B antibody. So if you got type B blood, the antibodies would fight off and destroy that donor blood because it doesn't match yours. If you have type B blood, then in your plasma, you're going to have type A antibodies because we're going to have antibodies that fight off foreign antigens. And if you have type B blood, type A is foreign to you. Now, if you have type O blood, you have type A and B antibodies in your blood plasma because your body has never seen the type A or the type B agglutinogen because you don't have anything on the surface of your red blood cell. So you'd have both types of antibodies to fight off the other blood types. And then type AB, you wouldn't have any antibodies in your blood plasma. You may be wondering, why would this person not have any antibodies to fight off the donor blood type that doesn't match their own? Well, actually, a lot of blood types would match them if you think about it, because they have type A, they have type B. Their body would recognize both, so they don't need antibodies to fight off what's foreign to them. Neither the A or B antigen is foreign to them. So blood may contain the preformed anti-A or anti-B antibodies. A lot of times your body doesn't contain preformed antibodies. This is actually rare for the ABO blood groups, but we do know it occurs. And they're going to act against transfused red blood cells with ABO antigens that are not present on your own, or if you're the recipient, your red blood cells. So we would see things like anti-A antibodies, anti-B antibodies. They generally form in the blood at about 2 months of age, and by the time you reach adulthood, they would definitely have reached kind of peak levels. But they would have reached adult levels by age 8 to 10 years. I highly recommend this table. It's a great table looking at the ABO blood groups, table 16.4 in your lecture textbook. We have all of the blood groups over here on the left. We have what antigens or agglutinogens are on the surface of these red blood cells. We have what antibodies, if any, are in the blood plasma. This is a great descriptor of the blood cells themselves and what's on them, and what's in the plasma, what's kind of floating around them. So in that white space, we're saying that's the plasma. So you see type O, we don't have A or B antigens on the surface of this red blood cell. Type A, there's A antigens on the surface of this red blood cell. Type B, there's B antigens, and type AB, there's both. The type AB blood group is actually known as the universal recipient because they can receive AB, AB, and O blood, whereas type O is known as the universal donor, so they can donate to anyone because there's nothing on their red blood cells to interact with anything. There's no A and there's no B, but they can only receive type O. Let's now talk about the Rh blood groups. Rh stands for rhesus. There's about 52 named Rh agglutinogens or Rh factors. There's C, D, and E are the most common. We're going to be looking at the D antigen, which is a type of Rh blood group. Rh positive indicates that someone has another surface marker on their red blood cell. That means they have the D antigen. So if you're A positive, you have an A surface marker and an Rh or D surface marker. If, say, you're A negative, you have an A surface marker on your red blood cell, but you do not have an Rh, or what we're calling a D antigen, on the surface of your red blood cell. So that positive or negative that you see next to the ABO blood groups, that is saying either a person does, positive, or does not, negative, have this D antigen. And remember, the D antigen is an Rh blood group or factor. Anti-Rh antibodies are not spontaneously formed in Rh negative individuals. So that means, unlike the ABO blood groups, you're not going to pre-form antibodies against Rh positive or this Rh antigen. So if someone has Rh negative blood and they come into contact with Rh positive blood, then they actually get sensitized. This first time they come into contact with a foreign substance, their body will recognize it as foreign, and that will prompt an immune response. And normally this first immune response, nothing happens. We don't know that our body's becoming sensitized. But the second time you come into contact with this foreign object, then our body mounts a huge immune response. The first time they were getting used to it, they were kind of seeing what they needed to do in order to mount an immune response. Now, this isn't a huge issue. Clinically, we generally only give someone who is, say, Rh negative, negative blood, someone who is Rh positive, positive blood, even though they can get positive or negative, because we just want to assume that anyone who has Rh negative blood has come into contact with positive before. Because if we're wrong, or if they're wrong and they tell us no, they haven't, we could cause a mismatched transfusion reaction, so a mismatched blood reaction. This is also a big concern in another instance. For example, anti-Rh antibodies form if an Rh negative individual receives Rh positive blood. So an Rh negative mom who is carrying an Rh positive fetus could actually become sensitized during the birthing process of her first child. And by the time she may or may not have a second child, she's sensitized, and if the fetus is again Rh positive, her body will attack the blood of her unborn child. So the second exposure she may experience to Rh positive blood could result in a typical transfusion reaction. This transfusion reaction, when it occurs in mothers with unborn children after they've been sensitized, is called hemolytic disease of the newborn, or erythroblastosis fetalis. It only occurs in an Rh negative mom with an Rh positive fetus. Again, during the first pregnancy, the Rh negative mom is exposed to the Rh positive blood of her fetus during delivery. The first baby's born healthy, but she's been sensitized, so her body synthesizes anti-Rh antibodies. So during her second pregnancy, she has anti-Rh antibodies in her blood, and that blood, including the antibodies, can cross via the vascularization to the placenta and destroy the red blood cells of the Rh positive baby. Again, that's during the second pregnancy. The baby would need to be treated with pre-birth transfusions and exchange transfusions after birth if they suffer from hemolytic disease of the newborn. However, there is the RhoGAM serum, or sometimes called the RhoGAM shot, and that contains anti-Rh, but it prevents the mother from becoming sensitized during her first pregnancy. So the RhoGAM shot is usually administered at about 28 weeks and then shortly before birth. So there are other types of transfusion reactions. There's not just transfusion reactions regarding Rh, but transfusion reactions occur if there's mismatched blood, and that's infused into a recipient from a donor. The donor cells are attacked by recipient's plasma. So it's the donor cells that get attacked because they don't match the recipient's blood, and they're getting attacked by antibodies in the recipient's blood plasma. We call the antibodies sometimes agglutinins. And they agglutinate or clump and clog small blood vessels. That can be dangerous, but they also cause the rupture and release of hemoglobin into the bloodstream, which is the most dangerous. Not only are we diminishing oxygen carrying capacity by rupturing red blood cells, we're decreasing blood flow because we're blocking or causing that clumping. And that would be, or go beyond blocking blood vessels. And then hemoglobin doesn't filter well out of kidney tubules and can lead to renal failure and death. So we just treat the symptoms: fever, chills, low blood pressure, rapid heartbeat, nausea, and vomiting. But our main symptom treatment is going to be at preventing kidney damage with fluids and diuretics to not only dilute the blood, but also wash out hemoglobin. So don't forget, as we go through this unit, some of kind of our mainstays that we're learning as we learn about blood groups, like type O is the universal donor, type AB is a universal recipient. But this can be misleading as other agglutinogens that cause transfusion reactions must also be considered. Next, we're going to be looking at autologous transfusions, where a patient pre-donates their own blood that is stored and available if needed. So autologous transfusions are going to be where a patient knows that they're going to have surgery, say for instance, and they're going to need a blood transfusion during that surgery. So at an earlier date, they will donate blood and they won't have any problems or concerns about that blood matching their own because it's their blood. So that would be a purpose or use for an autologous transfusion. All right, let's talk a little bit more about blood typing. So donor blood is mixed with antibodies against common agglutinogens during blood typing tests. And if the agglutinogen is present, we'll see clumping. We'll see agglutination. So clumping of red blood cells will occur if there is the presence of that agglutinogen or that antigen on the surface of the red blood cell. And blood is generally typed for ABO and Rh factor in the same manner. There's also cross-matching, which is typing between specific donor and specific recipient, just to see if that donor is going to have a transfusion reaction if they donate their blood to that recipient. And what happens is you mix the recipient's serum with the donor red blood cells, and then mix the recipient's red blood cells with the donor serum. All right, and all that information is great, it's very correct, it's accurate, but let me just summarize what's happening. Say you were to test your own blood. If we were doing in-person labs, you would actually do this in your lab class, and what you would do is you'd get this little card called an Eldon card, and it would have 4 circles on it. And you can Google Eldon cards, see what they look like. You can probably watch videos about the process. If you have me for lab, I probably have a link to that video. But you just get this little card with these 4 circles on it. One's a control. But the other 3 circles it looks like something's dried in them. And what that is that's antigen. So you'll have A antigen dried in this little circle, B antigen dried in the other circle, and then the D or the Rh antigen dried in the other circle. So these are antibodies that are going to be able to recognize if you have these antigens on your cells. So you would prick your finger, you'd put a drop of blood and water in all 3 of the circles, the A, the B, and the D, and then you'd mix it together really good. And if you have type A blood, you're going to see clumping in the type A circle. That's a positive for you having the type A antigen on your red blood cells. What if you saw clumping in the circle that was labeled A and the circle that was labeled B? Well, that would mean that you have type AB blood. Now, what about that D or Rh circle? Well, if there's clumping in the Rh or the D circle, then you have the Rh antigen on your cells. Your blood type's positive, whether you're A, AB, B, or you had no clumping in the A or B circle, then you're type O. But you could still be O positive. You could have had no clumping in any of the circles except for the D circle. And that would mean that you have you have positive on your red blood cells, meaning you have the Rh antigen, even if you're type O. So it may sound a little complicated when we use terminologies like mixing donor blood with antibodies against common agglutinogens. So let me summarize that. If you're the donor, we would mix your blood against antibodies because we would know that if we got a reaction to a particular type of antibody, that you have that type of surface marker or antigen on your red blood cell. It's just kind of a cross-check. That's why cross-matching is such a good test. So here's what I was talking about. Now, this isn't an Eldon card. We're only seeing 2 circles at a time, but in this circle, there was anti-A antibodies. So if we put any A antigens here, we'll get a reaction. In this circle, there are anti-B antibodies. So if we put any blood cells that have B on it in this circle, we're going to get a reaction. So this individual's blood had a reaction in both circles. So they're type AB. That means that they have the A and B agglutinogens on the surface of their red blood cells. And if you're not liking agglutinogen and then me saying antigen, I'll go ahead and say this very clearly. an agglutinogen is the same thing that we've been talking about and calling an antigen. Agglutinogen is just more specific because if we get a reaction against an antigen from the ABO blood groups, it causes clumping, which is called agglutination. So we're just calling these antigens agglutinators, essentially, because of what they do. But same thing, agglutinogen, antigen on a red blood cell, same thing. All right, for this individual, we tested their blood, and we only got clumping in the anti-A circle. So they're only type A. There's no reaction in the B circle because they don't have any B on their red blood cell. Type B, we only got reaction in the B because they have no A on the red blood cell. This person, no reaction, no clumping, because they don't have A or B antigens or agglutinogens on the surface of the red blood cells. And one of the last things we want to talk about is just some diagnostic blood tests. A blood test is just an examination of blood. It can give us a lot of information on a person's health. We can see how many red blood cells they have, how many white blood cells. We get a platelet count. We can check blood glucose. We can get a percentage of the amount of red blood cells per blood sample. Low hematocrits are seen in cases of anemia. If blood glucose is high, that's check or a test for diabetes mellitus. Leukocytosis can signal infection. And thrombocytopenia can be a thing that lets us know that there's problems in hemostasis. But the microscopic examination of blood can reveal any variations in size or shape of red blood cells. You could diagnose sickle cell anemia this way. We could see an abnormally large amount of white blood cells or eosinophils of a specific type, if we were talking about white blood cells. Or we could see kind of weird colors that could indicate not only anemia, but many other disorders. A differential white blood cell count is going to look at the relative proportions of each white blood cell, things like neutrophils, eosinophils, basophils, lymphocytes, monocytes, and increases in any of those specific white blood cells can help with diagnosis. We could do a prothrombin time test or a platelet count to assess hemostasis. Remember, hemostasis is the stoppage of bleeding, which includes the formation of a platelet plug and coagulation. Coagulation, in one of those steps we talked about, need to turn into thrombin. CMP is a comprehensive medical panel. It's a blood chemistry profile or test that checks various blood chemical levels. So we could look at abnormal results that may indicate liver or kidney disorders. This may be indicated by someone not being able to make procoagulants or clotting factors. And then a complete blood count, or a CBC, checks formed elements, hematocrit, and hemoglobin. And that's it for Chapter 16, so make sure to review all parts. If you have any questions, please send me an email.